Hello doctors, welcome to Chennai Women's Clinic and Scan Center's Dialogue series. This is a part of our initiative to leverage technology to best serve the medical community through healthy debates and conversations. So I'm Dr.Deepthi Jammi, Fetal Medicine Consultant at Chennai Women's Clinic and Scan Center. We have today with us Dr. Nithya Ramachandran, who is a gynecologist who is a postgraduate from Government Medical College, Kottayam, and who is currently practicing at SIMS Hospital, Motherhood, and Cloud9, Chennai.
Thank you, Deepthi. So let us discuss about the soft markers which we see on ultrasound. See, soft markers, as we all know, they are not any gross abnormalities, but they definitely point about we have to open our eyes wide to look for any other underlying abnormalities which is being hidden from us. So yesterday I had a patient in my OP who came with a report. She was literally sobbing, telling that the fetus is showing an isolated intracardiac focus in the left ventricle. So Deepthi, how would you counsel such a patient?
Yeah, very true, Nithya, because a lot of second opinions we receive day in and day out with an echogenic cardiac foci in the left ventricle. This is the most commonest indication for a referral for fetal echocardiogram.
Okay.
And see, in earlier days, when the echogenic cardiac focus was brought into picture during an anomaly scan, it was linked to Down syndrome. This is how it started.
Okay.
So, when someone identifies an echogenic cardiac focus, the first thing we need to look whether it is a single echogenic foci. That's one.
Okay.
Two, whether it is in the left ventricle or in the right ventricle. So, and if it's a single echogenic cardiac foci in the left ventricle, look for the other structures. If all the other structures are normal, the fetus is cardiac-wise, extracardiac-wise, there are no anomalies, growing well, her background risk for Down syndrome does not change because the likelihood ratio for an intracardiac foci isolated is only 0.98.
Okay.
So it's almost close to 1. Her background risk, whatever screening she's done, whether it's age-related risk we have taken or a first or second trimester screening, her Down syndrome risk does not change based on this finding. So we can actually assure her, saying that this is very common in an Asian population. It's very much common in an Asian population, and this echogenic cardiac foci does not indicate any functionability of the heart.
All right.
The heart will be absolutely normal if it is structurally normal, and we can definitely reassure them that this is so common in an Asian population. Please do not worry about it, as it does not change the likelihood ratio for your Down syndrome baby in any way.
Okay. She would ask me that should they repeat a scan. So what do I tell?
See, the follow-up scan doesn't really change.
Okay.
She's going to be followed up as a routine any other mother.
All right.
And this is no longer considered as an important soft marker.
Okay.
And I don't think we should alarm the patient, because when I see an echogenic cardiac foci, I pretty much I tell them, I reassure them that, see, this is not anything abnormal. Don't worry, because we come across, because we are in this Asian population, we come across a lot of babies with that. And I call you up and tell you that this is what we have seen, but the echo is normal. So I think when we talk to one another, I think the reassurance factor is more with the patient.
Right, Deepthi. So as we tell nuchal translucency in our first trimester scan, we are here, we do nuchal fold thickness in our second trimester. So can you tell us more about the cutoff values of nuchal fold thickness?
So nowadays the awareness is much better when you compare it to like 5 years earlier, because most of the patients have their NT scans done, nuchal translucency done. So we rarely come across, we do, but we rarely come across patients who have not done their first trimester scan or a screening. So nuchal fold thickness, when we measure the cutoff, as you said, 3 millimeter for the NT, it's around 6 millimeter for the second trimester.
Okay.
And an isolated NFT, like how the same way I told for an rest of all structures have to be screened, because an isolated NFT, nuchal fold thickness, carries much more chances of a risk ratio, because the likelihood ratio is as high as around 3 to 3.5. So your background risk increases up to 3.5 times.
Okay.
So an isolated NFT has to be taken up with caution. The rest of the baby has to be thoroughly detailed anatomy scan has to be done. And say if you offer, so obviously the next question is going to be, will you offer
karyotyping?
And karyotyping you need to offer only when it has an additional marker, or there is no consensus as such. It's like really debatable whether you do a KT or not.
Okay.
If your background risk, your age-related or a screening risk is changed 3 times because of this NFT, and that falls into the final risk as high risk category, you definitely have to offer her a karyotype. Whether she is going to get it done or not is the patient's choice. But yes, when the adjusted risk with the soft marker falls into the high risk category, you definitely have to offer them a invasive test.
Okay, Deepthi. So nuchal fold thickness has to be taken up seriously with caution.
Right. That's
okay.
Right.
Now, other soft markers which we commonly come across are single umbilical artery and echogenic small bowel.
Yeah.
So, what is your take on that?
Yeah, that's true, because let's split it into two, because single umbilical artery per se has been studied with association of the chromosomal abnormalities.
All right.
Again, when we talk about soft markers in general, no, the concept is isolation. If it is isolated, having said that, like all the other systems are normal, you're able to actually see two kidneys and or the bowel looks fine, and the cardiac fetal echocardiogram in a single umbilical artery looks good, there is no CNS anomalies, then you counsel her that this could be a normal variant. While developing, instead of two umbilical arteries, there is only one umbilical artery which will actually do the job which is supposed to be done. The other important factor is growth.
Okay.
Because there's only one artery which is carrying the nutrition. Obviously, we will want to get a growth scan done in these patients. Other than that, for an isolated single umbilical artery, the background Down syndrome risks do not increase substantially. So we do not offer them invasive screening for single umbilical artery per se.
Okay, okay. Now coming to ventricular megali, I think even that is quite common. Whether it is mild ventricular megali, how would we counsel the patient, Deepthi?
Okay, so see, mild ventricular megali in a second trimester scan, we would have to actually look on whether it's mild, moderate and severe. As you said, it's mild, then we have to say whether it's unilateral or bilateral.
Bilateral, okay.
So that's very important, apart from the other intracranial anatomy. And then the other structures as well in the fetus, and how is it growing, how is the liquor and activity. So say if it is a mild ventricular megali, by mild I mean to say it's within 10 to 12 millimeters, and it is unilateral. Unilateral, the prognosis is much better, even if it's bilateral, and if it is non-progressive, say it's staying at as mild throughout the pregnancy, we can actually tell them 90% of the babies do really well without any neurological developmental delay.
Okay.
That's what the parents want to know. At the same time, 10 to 11% of the babies could have a mild neurological development issues, probably in learning or aggressive behavior or such. And we actually involving an MRI at this stage in late second trimester or in early third trimester, 6 to 10%, it can actually tell us additional information about some sulci or gyral abnormalities as well. And in a mild ventricular megali. So a close look is essential. We can reassure them if it is non-progressive, and if it's unilateral, it is much better.
All right.
And even if it's bilateral, we can tell them that 90% of the time, these babies do really well without a developmental delay.
You've made that really simple and clear, Deepthi. Now, there's a recent soft marker which is being added, that is aberrant right subclavian artery. So, what as an obstetrician, what should I know about that?
Okay. See, even aberrant subclavian artery, which has come across recently, it's an incidental finding. Actually, you would be surprised if I say that plenty of old age patients who have their CT angio or coronary angiogram, they actually identify as an variant. They just see all this while they would have been normal. They wouldn't have even known that they had an aberrant right subclavian artery. Those were all incidental findings. But then we started looking into aberrant right subclavian only because of its association with Down syndrome. Because the aberrant right subclavian artery, again the likelihood ratio is around 3 to 3.5.
Okay.
It increases your background risk to 3 to 3.5. So again the isolated word comes to play. Rest of the fetal cardiac anatomy is normal. Rest of the fetal anatomy per se, their structures are normal. Then you don't have to really worry about an aberrant subclavian artery. Karyotyping again is debatable. Initially, we were doing karyotyping. We were offering karyotyping when there wasn't much data on aberrant right subclavian.
Okay.
But most of the karyotypes turned out to be normal. So then we started to know that isolated aberrant subclavian artery without any other soft markers did not increase the risk that high, like how we were actually thinking. So the option was given to the patient.
All right.
So whether taking up a KT or not, and whether it falls into the high risk category, we will have to work around the numbers with a based background risk.
Background risk, all right.
Yeah.
Okay, Deepthi, so we've spoken about all the soft markers in the second trimester. So if I ask you, what are the conditions in which you have to offer amniocentesis? So what would that be?
Yeah, see, a couple of things it came into our discussion as well, and the one we missed is that echogenic small bowel. See, echogenic small bowel is another very common factor actually. Echogenic bowel is so common in second trimester. There are so many indications as early as in the first trimester, because if the patient would have had a history of bleeding,
Okay.
History of bleeding, when the baby swallows the own amniotic fluid, it can appear bright white in scan.
All right.
That's one of the most common reasons, and could also be a normal variant.
Okay.
In the same time, it can be a marker for evolving obstruction as well. So we have to put this all into their mind, apart from our Down syndrome screening data. And in spite of doing all this, we call them back for a growth scan.
I think, Deepthi, we have to talk more on soft marker which we come across very often. That is about unossified nasal bone.
Yeah.
And when do we offer karyotyping, or should we or shouldn't we for such patients?
So, see, unossified nasal bone is another difficult challenge for it. It's extremely challenging for us to counsel such patients, because they either come to us directly for a second trimester ultrasound, where they would have had either an imaging of nasal bone done or not in their first trimesters. So in a second trimester per se, when we see an unossified nasal bone, again associated with any other marker or in isolation, the standalone point of unossified nasal bone has an highest likelihood ratio of 6 to 7 times.
Okay.
So when you include a second trimester absent nasal bone in your background risk, very likely that it will come to a high risk status. So you need to definitely offer them amniocentesis, like how we spoke about who and all we offer amniocentesis, like isolated NFT and unossified nasal bone. Even when we talk to about URSA or ventricular megali, we always have to do a background risk assessment and an adjusted final risk. So when we do an adjusted final risk, more so we'll get positivity with unossified nasal bone and NFT. So these two are the main things where we actually counsel them and sit them and talk to them about an amniocentesis per se. Ultimately, it is their choice. After knowing the pros and cons of a direct invasive procedure, it's up to them whether they want to take up the procedure or not. But definitely, in second trimester, if we identify an unossified nasal bone, we would definitely offer them a karyotype.
Okay. Is isolated short humerus, is it significant?
Yeah, when you short long bones, when we measure, the routine, what we measure is femur.
Yeah.
But we have actually seen short humerus is more significant marker for Downs than short femur. Now, overall short long bones is it. But then when we see short long bones, the first thing would go to femur length. We will also have to routinely rule out a familial shortening also, if the mother or the father is short. So that also we have to rule out. And a short humerus is definitely more significant than a short femur.
Okay. So Deepthi, my last question would be, how much to reassure after a routine anomaly scan?
That's a very, very good question, Nitya, because very difficult to answer, honestly. We try to do our best in any targeted evaluation of the fetal anomalies. The solid structures is what we usually see. We usually tell them, see, occult anomalies or evolving anomalies, or anomalies which are related to the gastrointestinal or a GIT tract, may not be evident as early as in your anomaly scan. So yes, we can reassure them, definitely. That's why we have high-end machines and we do scans. But we have to put it across to them as well that there are certain things that will evolve, might evolve, and we are looking at it a developing baby. So that's not the baby which is fully formed. So we are looking at a developing baby which is still yet to develop its intestines and genitourinary system. So I think that we need to put it across in them. Fairly, yes, we can reassure them that the major organs are normal, but not too much. We'll definitely have to put them across in that aspect as well.
So I think the discussion on soft markers is made very simple and clear.
At least we know the dialogue between the obstetrician and a fetal medicine consultant is very important, because in counseling couples and families with the soft markers, it becomes very essential that we speak the same language. Because even let it be a small echogenic cardiac, we know that it is not going to increase the background risk, but unless and until we have a rapport and we talk among ourselves, the patients would feel much better to continue the pregnancy. So thank you, Dr. Nitya. And if you want to look more about this and you want more information, please log on to www.chennaiwomensclinic.com. You can also subscribe to us at Facebook or Instagram or YouTube. Feel free to write to us or WhatsApp us at 733-877-733. Thank you.